So our two main presenters, as you might know, is Susan Johnston and Steph Campbell. And Susan earned her BA, Master's, and Education Doctorate degrees from UCLA and serves as Compassion and Choices Orange County Co-Action Team Leader with Steph. Their outreach efforts include conducting community presentations on the California End of Life Option Act. Susan and Steph are both committed to helping establish the normalization of medical aid in dying as an acceptable option for terminally ill patients in California. Steph, of course, is our very own president of this chapter. She's on the national board. We also know her from League of Women Voters. She does an awesome presentation on the California propositions, trying to make sense of those for us. And of course, she's involved with Women for OC, among probably other things that I'm forgetting. So Steph, with that, let me hand it over to you.
Okay. Let me.
I'll stop sharing here for you.
You stop sharing and then I'll start. Okay. And can people see my screen? At least one person has nodded, so I'm assuming that everyone can. All right. So today we're going to talk about how to access the California End of Life Option Act. And we're also going to talk about Richard, who many of you know, my late husband, who was a member of this chapter and who did use medical aid in dying, and we'll talk about that experience. And we are also going to talk about the new law that we are trying to get through, SB 380, which is going to make some changes to the law as it exists. So we'll talk about all of these things as we go through. And we will be going back and forth between Susan and myself, and hopefully it will be smooth and seamless, but don't always count on such things. Susan.
All right. Well, Steph and I are both thrilled to be active members of Compassion and Choices. They are the nation's oldest, largest, and most active nonprofit working to improve care, expand options, and empower everyone to chart their end-of-life journey. And we strongly believe in patient-centered care where each person is in charge of making their own healthcare decisions by being fully informed on the full range of end-of-life options. Their outreach effort in California, we are focused on providing presentations to the public so that they can be better informed. In addition, Compassion and Choices wants to educate healthcare professionals because even though the law has passed, there are healthcare professionals who desire more information and need to be informed so that they can help their own agency be more effective. And they also provide technical assistance so that the healthcare agencies can actually create policies that are known to all their staff members and to the patients.
So Dr. Atul Gawande, who is actually on President Biden's COVID team, wrote a book called Being Mortal, which if you haven't read it, I really recommend it. And in that book, he says, life is meaningful because it's a story, and in stories, endings matter. And so during this presentation, one of the things that I will be doing is sharing my story and Richard's story and how we learned together the importance of doing a good ending and that endings do matter, but it's only one part of the story. So this is Richard. And this picture was taken on his last hiking trip. He utilized medical aid in dying in March of last year, so it's been just a year since he's been gone. And I have to say how grateful I am to Compassion and Choices for the work that they did to make this law happen in California. And it made all the difference to his life and to my life. So I will go ahead and share some of my thoughts and experiences. Um, this picture is especially poignant to me because it was taken on a hiking trip that he really wanted to go on, and it was an 8-day trip in the Sierras, and he was really hoping that he could do this. And unfortunately, he had to back out right at the beginning of the trip, and I had to go retrieve him from what you can see from the background in the picture was a very beautiful place. But he was just too sick at that point to continue. And that was in August, and he died in March. Um, I think that everyone has the concept of how they want to die. They want to die and have it be at home with loved ones. They want their pain and discomfort handled, and whatever spiritual values they may have, they want respected, and they certainly don't want any church imposing a belief on them that is outside their belief system. And this is what the ideal is. I can tell you from experience that this ideal is not always the reality. One of the things that I learned is that although Richard was at home when he died, he wasn't aware that he was at home. And so these are the kinds of things that you learn as you go through this process. So one of the things that I learned is that there's a big difference between understanding the process. You know, intellectually, you can go through and say, this is what the law is and this is what the process is, but it is completely different than when you experience it firsthand. Um, and it's important not to delay starting the application steps so that suffering doesn't increase to intolerable levels before the medication is received. And some people ensure that they've got the medication on hand, and then they choose for whatever reason not to use it. I think that one of the mistakes that Richard and I made was not processing the application quickly enough. There was a week gap that we allowed to have happen, and that was a big deal, and that made a difference. So I can only encourage people that if they once they start the process, that they move forward, and it's better to have the medication on hand and not use it, or know that it's there and you can wait to use it, than to not have it when you really need it.
The current law is entitled the End of Life Option Act. And the word option is crucial because Compassionate Choices was adamant that all patients in the state of California really understand the full range of options available to them. And the first option listed here is refusing or discontinuing treatment. And often patients think that if their doctor says this is our treatment, that they don't have the right to say, this is not something I want to continue, but it certainly is one of the options. And then hospice care is another option. And for patients who want to use the law and access medical aid in dying, they are strongly encouraged to enroll in a supportive hospice. And we'll be covering what makes a hospice supportive later in the presentation. But that makes all the difference to be enrolled in a supportive hospice. And we saw that with Rich at the end of life. The other option is voluntarily stopping eating and drinking. And my mom lived to be 103, and she opted for this because she didn't qualify for medical aid in dying because she didn't have any terminal illness, but she was done. And the thing I learned about the voluntarily stopping eating and drinking option is that it takes a very long time. And one needs to be very, very carefully supervised during that time. it can be up to 2 weeks. Then the next one, continuous deep sedation, is usually offered within a hospital setting, and that's where the pain cannot be controlled through palliative care, and the patient is put into a deep state where they're not really aware of anything in order to control the pain. And then our last option is the one we're focusing on today, which is the ingestion of medical aid in dying, a specific cluster of medications prescribed by a doctor to assist terminally ill patients who choose to end their suffering. So that's the full range of options available to all of us. We define medical aid in dying as a safe and trusted practice in which a terminally ill, and these are in red because these are the criteria, terminally ill, mentally capable adult with a prognosis of 6 months or less to live. That prognosis is by a certified doctor, has the option to request from their doctor a prescription for medication which they self-ingest to end suffering and to die peacefully. And this medical practice is also known as death with dignity.
So support in California is actually pretty high. In October of 2019, the California Healthcare Foundation launched a comprehensive survey of serious illnesses and end-of-life care. And their report showed that 75% of Californians were supportive of the End-of-Life Option Act. And in fact, the majority of all demographic groups believed that having this option was very important to them. And you can see it varies a little bit by ethnicity, but there's not, huge differences there. So here we have some data from the last 3.5 years. Data is always lags over, here you are, it's 2021, and we do not have anything beyond 2019. But then 2020 was a very strange year, as we all know. So looking at the data from the first 3.5 years, we know that over 1,100 patients were enrolled in hospice. 1,985 prescriptions were written, and 1,283 Californians used medical aid in dying. And when you look at those numbers, they are really small. When you think of the population of California and that you have only just over 1,200, almost 1,300 people who used it, it is a very, very small amount. There has never been a single incident of coercion or abuse. And in fact, in over 20 years of having medical aid in dying laws across the country, starting in Oregon, there's never been a single case of abuse. And, a lot of times when people were opposing this law, that was a concern, but that concern does not appear to be valid. Why are the numbers so small, which is, the question that everybody asks. And that's because of patients who have problems accessing the law. It is not always easy to access this law. There are a lot of very well-intended safeguards that were incorporated into the law. But some of these are such barriers that people were not able to overcome them to get the medication when they needed it. And we do know that from a Kaiser Southern California study that nearly a third of eligible terminally ill patients who otherwise would have qualified for the law died during the mandatory 15-day waiting period, unable to access this compassionate option. And I actually belong to a bereavement group through Hoag Hospital. And one of the women in my bereavement group, her husband had wanted to use medical aid in dying, but ran up against this 15-day period, and that was tough. But the momentum continues around the country. As I mentioned before, it's been in Oregon for 20 years, and that's really where it started. We were the 5th state to authorize medical aid in dying, and there are now 10 states and Washington, D.C., all of whom have authorized, and they're on light blue on the map. The one that isn't on the map that has authorized it is New Mexico, and they just did it. So that this map needs to obviously get updated. And the ones that are in dark blue are in 2020, they all had medical aid in dying legislation in their assemblies and state senates, and are looking to authorize as well. So we're feeling pretty positive about how that's going through the country. So this is Americans United for Separation of Church and State. And so I do want to talk about the ongoing challenge of religious opposition. 71% of Americans feel that personal decisions about health should take priority over a healthcare facility's religious values. Yes, we're looking at you, Hoag Hospital. Um, and at life's end, religious healthcare systems often dictate these care decisions, regardless of what you have written down, regardless of what your preferences are. And Catholic facilities, which comprise about 80% of all religious healthcare systems, use ethical and religious directives, and that are among the most restrictive and vigorously enforced policies at the end of life. And these directives, and this is just appalling to me, I will just make that statement. These directives state that if a dying patient's pain is uncontrollable, a doctor should help their patients appreciate the Christian understanding of redemptive suffering. I see Felicity shaking her head. But yes, that is what they believe. And from a perspective of separation of church and state, I do believe that it is important that um, religious organizations do not dominate a state law that says, you know, this is what the law should be. So yes, I feel very strongly about this. So, the ethical and religious directives of the Catholic Church require medical assisted nutrition and hydration at the end of life, regardless of what you have in your advanced directive. I know that in my advanced directive, I say no assisted nutrition. Um, my mother had assisted nutrition at the end of life, and it was truly awful. Um, Catholic hospitals have grown by more than 28% in the last 20 years. Um, one of the things that's so interesting is it can be really hard to figure out if your hospital or your hospice is a Catholic or a religious based institution of any type. There's nothing that they're required to put on their website. You know, they don't have to put a cross and say, we're a Catholic hospital or we're a Catholic hospice. And sometimes you sign up for these things, and by the time you realize it, it may be too late. And as Susan said, most Catholic hospitals prohibit doctors from providing information to the patient and to the family about all of the end of life options, and not giving referrals. If they don't want to do it, we would say fine, they should not have to do it. But it would be very nice if they would then refer you as a patient to a healthcare system that is supportive. Um, if you're a physician within a Catholic hospital and you believe that medical aid in dying is a good option for your patient, and you're willing to do that, um, not on site of the hospital, outside of regular business hours, they can be prohibited by the hospital from doing so. And the church can control every aspect of hospital management. Um, for example, Hoag Hospital physicians report that there was an anonymous hotline directly connected to the bishop's office. Well, it was established for people to complain if they believed immoral procedures were taking place. Well, I need them to know that what's immoral for me is not necessarily immoral for them, and the other way around. And Catholic hospitals, hospices, and care facilities are allowed to bill Medicare and Medicaid. Their right to use taxpayer funds while restricting services not allowed by their religious doctrine is protected by the First Amendment, and I would say that it shouldn't be.
So currently, our law is set to end, and they call it sunset, in 2026. And in order to successfully pass it originally in 2016, some legislators required that a sunset clause be included. And that's why we're going to be covering information about the replacement law that's now going to be considered. Without additional legislation, the option for patients to use medical aid in dying will no longer be available in California as of 2026. And we are preparing for a variety of challenges, some of which Steph just described, from religious opponents when we try to extend the bill. And our intent is to successfully renew the law and have it be installed without a sunset clause going forward. And we will discuss more details about that later. But that's a picture of Susan Eggman. She was the Senate sponsor of this new bill coming up, and she's a wonderful proponent and supporter of all that Compassionate Choices is about.
So, California Senate Bill 380 has some proposed changes, and I did put in the chat, and I'm not sure whether people are able to access it, a fact sheet, and I think that we also added it to our website and our meetup page. And anyone who has not been able to access that file, if they put their email address in the chat, I will send it to them separately. Among the proposed changes are, as Susan said, to permanently eliminate the sunset provision that required the expiration 10 years after initial passage. This is crucial. I mean, those of us who are on the call at some point want to use medical aid in dying. We don't want to have to worry about a sunset clause. It will require healthcare facilities to post medical aid in dying policies on their websites. It will waive the 15-day waiting period for patients at highest risk of survival. I mean, those last 15 days can be agonizing, and it's really good if you can go ahead and eliminate that. And it would remove gag clauses on medical providers that prevent them from sharing accurate information about medical aid in dying to their patients. And I think Susan brought up earlier that if you go to your doctor and say, I'm interested in medical aid in dying, that they are required to go through all of the options that Susan listed as possibilities. But a lot of doctors will not talk about medical aid in dying, and this would help eliminate that. So it would also authorize licensed clinical social workers and licensed professional counselors to provide counseling services relating to medical aid in dying. There's a thing in the current bill called the final attestation, which has always struck me as kind of odd, because after you've used medical aid in dying, they're supposed to provide this final attestation. Well, obviously, you're already dead, and so you can't. But on the other hand, it was a way for them to capture data about who was using it and who was not using it. But it just, I don't know, it seemed kind of silly. Um, it will clarify that medical providers should document and date requests for medical aid in dying, so that if a patient needs to transfer care, they will be able to do so. And also, it should clarify that if a patient is in a facility, a healthcare facility of some kind, that they should be allowed to utilize medical aid in dying in that facility. Let's see. So the legislative timelines are critical. And one of the reasons that we have been really pushing to get people to endorse this bill, and there are links for that in the chat, are because of these super tight timelines. So the Senate health hearing happens this week, this coming week on Wednesday. And then there's a judiciary hearing, which will either be March 29th or April 5th. And then after that, it goes to the Senate floor. And June 4th is the deadline to pass the bill. Well, if you've worked with, on bills in the assembly, you know how hard it is to meet, dates like this. And then July 14th is the deadline for the assembly policy committees to pass the bill. And so it starts out in the Senate, then it moves to the Assembly. In early August, the bill moves to Assembly appropriations, and September 10th is the deadline for the Assembly to pass the bill. So you can see, how tight everything is. And then if the people in the Assembly amend the bill in any way, it has to go back. Sorry about that. It has to go back to the Senate for a concurrence vote. By October 10th, the governor must sign, veto, or take no action. And of course, with the recall that may be in process, we don't know how that is going to impact this. But if he signs or takes no action, it will become law on January 1st, 2022, which is, of course, what we are hoping for. And it's really important that the Assembly and the Senate know that there are a lot of people who want this to happen. Otherwise, they'll take the easy way out, and it won't happen. So we need people to endorse and support the effort. We're not even asking for money, but we would like to have people endorse, and there are links in the chat so that you can endorse either as an individual, or if you're a representative of an organization, your organization can endorse as well.
And on the previous slide, before I start my slide here, the link makes it so easy to enter your information, and it goes right to the appropriate people. It just takes a few minutes. So that would be wonderful.
One question, who is the author of the bill in the Senate?
Dr. Susan Eggman is the sponsor.
Oh, she's the sponsor. And where is her district? Do we know?
Oh, I should know that. I don't know.
I'll look it up. Well,
okay, and let us know when you know. This slide is very important for all of us to understand at a very deep level, because as you talk to family and friends and colleagues about this, there is kind of a flagrant use of the word assisted suicide. And it's really important that we make the distinction. In the law, it actually says medical aid in dying is not considered to be the following: suicide, assisted suicide, homicide, or euthanasia. And suicide occurs when people take their own life, when otherwise they would live a long life. So they are distressed, they are depressed, they take their life when they could live many more years potentially. People who choose medical aid in dying are absolutely not choosing to die. And that is the distinction that we really need everyone to understand. And when you share this content with others, that you also become a spokesperson for us, and that you share that intent also. They're not choosing to die. Rich was not choosing to die. He was choosing a peaceful death over an extended and intolerable one. And that's what medical aid in dying allows the citizens of California. and those 9 other states. So we hear this assisted suicide bandied about, and every time I hear it, I try to tactfully and nicely help people understand the difference. So, okay. We've mentioned this before, but the legal provisions are written into the law, and I assume, Steph, that's not going to change with the new law. The following documents are not affected when medical aid in dying is used as an end-of-life option. So wills, contracts, insurance, and annuity policies all stay the same. The cause of the end of life is the disease, not the method. So that's important.
So one of the things about medical aid in dying is that the option provides comfort to a lot of people. And a lot of people have reported that simply having the prescription that they know that they can fill in very short order gives them incredible peace of mind. And surviving family members, and I can speak to that as a surviving family member, that their grieving process was positively impacted by this. I know that I felt that this was what Richard wanted. He did it when he wanted it. And he had control over how it all went. And that has made it very much easier for me. And as I think back on him, that this was something that I could help him do at the end, and it had great value to him.
The eligibility requirements are not going to change with the new law that's being proposed. One must be a California resident, 18 years or older, terminally ill, verified by a medical professional with a prognosis of 6 months or less to live. And what we learned when Steph and I were engaged in this process, that one of the ways to help a physician come to terms with allowing a 6 months or less declaration is to ask the physician, if I discontinue treatment, all treatment, how long might I expect to live? And at that point, the physician would be more likely to say, yes, it would. You are ready for hospice. It would be 6 months or less. And I think, Steph, that's what you ended up asking, right?
Yeah, I did.
Okay. The other criteria is to be capable of making medical decisions, and that mental capability is determined by the physicians who prescribe the medication. And the last one is the ability to self-ingest the medication. Patients are allowed to use a feeding tube or anal catheter. It's just that they must be able to push the plunger themselves. So it gets to be kind of those fine points of technical self-capability, if that's a word.
So this slide is interesting, and the reason that it's so interesting is that Compassionate Choices will tell you the most important thing you can do is talk to your doctor and find out if your doctor will provide you a prescription should the need arise. And I'm here to tell you from my experience that this is not true. And um, and the reason that it's not true is what you really need to find is a supportive hospice who will then help you through this process. You know, the physicians that Richard used were all through Hoag. They would not have been allowed to prescribe for him or help him down this road in any way. But we were very fortunate, and I owe a great debt of gratitude to Susan for this in identifying a hospice that would support medical aid in dying. And when I went to Valley Oaks Hospice, I went to their website, and right on the front page of their website, it says supports medical aid in dying. So I knew I had found the place that we needed to go. um, it is, as Susan said, important that you find out from your current physician what the prognosis is. And in the case of Richard, what had happened was he had taken different kinds of anti-cancer medications, and then he had gone through some chemo, and then chemo wasn't working. And we very bluntly said to him, okay, so what are the options now? And we kind of forced him to say there were no options. And that way, he said that he would send a notice to the hospice of our choice that that he had 6 months or less, and he did that. And the next day, the hospice people were at our house, and everything moved forward. But it is that question to your doctor to find out what your prognosis is very important. And I would say that before you ask that question of your doctor, you have a hospice in mind. And there are a couple that are very clear about their support, and some are more supportive than others. I cannot say enough wonderful things about Valley Oaks. So there you go.
Staff, could I just say one quick thing that I learned from all this process? That the key is that you can't go to a hospice apparently and ask to be admitted. Some people think you can, but then they would be accused of recruiting patients. So the ticket into a hospice is a physician writing a letter or contacting that hospice, giving official permission. At least that's how we understand it right now. It may change, I don't know, but that was a key piece of the process that many people really don't know. So I just wanted to say that. Thank you.
So, as I said, Richard's oncologist was not allowed to prescribe the medication because of Hoag's policy. But he did write us a referral to the hospice of our choice. And that is when we found Valley Oaks. Thank you, Susan. Um, and the hospice, the hospice was amazing. I just have to say, they were extremely supportive. And one of the things that they did that was so supportive is they managed the entire process. So when we first met with the hospice director of nursing, he came out and filled out all the paperwork, and we told him that we wanted to use, when it came time, we would want to use medical aid in dying. And he immediately did the written paperwork. The first thing has to be a written request. So he did the written request for us. And along the way, they did everything like that for us. So it's really important that you find a good hospice like this one. And Valley Oaks is really good. So a supportive hospice is one that allows staff to be present at the time of medication ingestion. And obviously, we had one of the nurses from Valley Oaks who was there, and we had actually ended up doing the medical aid in dying earlier than we had anticipated. And we just called over to Valley Oaks, and they said, the nurse is on her way and she'll be there as long as you need her to be there. And it was great. So at the time of writing this slide, there are 136 hospice facilities who've adopted policies supportive of patient choice. I do not know if that number has changed. I would hope that it has increased, but I don't have any numbers. When you do contact a hospice, the questions that you need to ask are, what's your policy on medical aid in dying? How will you support me if I want to use medical aid in dying? And will a caregiver be allowed to be in attendance when I take it? And you need to know the answers to all of these. With Valley Oaks, it was all on their website, and I didn't need to ask, any questions. But if you go to a hospice that you think is supportive, or you don't know whether they're going to be supportive or not, it is up to you to find the answers to those questions. And so the sooner you do that, the better off you're going to be. You don't want to wait until you're ready to go in hospice to find this out.
Steph, before you leave that slide, it just occurred to me that I just spoke with a lovely lady in Laguna Woods who had helped her dear friend, and the dear friend belonged to Kaiser, and they had a patient navigator that helped them with this whole thing, and that was their version of hospice within Kaiser. And we don't want you to think that you have to have a hospice nurse at the time. The friend opted to just have her dear friend with her, which was fraught with peril a little bit because the friend was put in the position of having to manage the medications. So I was so impressed, Steph, with how supportive and competent the hospice nurse was that you had, that I think maybe we didn't discuss this before, Steph and I, but I think we might recommend that one has a medical professional there who can help manage, because it's a stressful time.
Yeah,
So,
I would definitely recommend that.
Yeah.
Yeah.
Okay. So the law requires a certain sequence of events, and we've covered a lot of them already, but after obtaining the medical referral for hospice and enrolling, there's a connection made with a doctor who will assume the role of, the label is prescribing physician. And the prescribing physician must meet in person, or now it's all right through a visual telemedicine assessment. Since the pandemic, they've allowed this now. And it will probably continue to be that way. And then the next step is to complete a written request for medical aid in dying. And that form is provided, at least within the context of this hospice. They have the form, and then it's completed and submitted, and it can be at the time of application to hospice or at the initial meeting with the physician or a little bit later, but there's the oral and the written request. And then there is the physician that has a different label, called the consulting physician, who confirms the patient eligibility. So when they made the law originally, they didn't want it to all be on the shoulder of only one doctor. And usually the prescribing physician will know the consulting physician that is their partner in this process. And that is usually, the consulting physician is usually not have to be found by the patient. And the hospice, as we say here, can arrange the meeting, which can take place also via visual telemedicine.
So before we go to the next slide, I just want to tell you that when we got to this point for the consulting physician, the hospice said, well, you can, here's the consulting physician's name, and you can do it over FaceTime, and, that's all you need to do. Well, we didn't have FaceTime on either of our phones. And of course, that was, a great panic. How are we going to do this? And we tried several things and none of it worked. So the man that runs the hospice drove out with his iPhone so that we could do FaceTime with the physician. So when I tell you that they were wonderful, they truly were.
So the last part is the one that you've heard us discuss already, was the 15-day waiting period. So the second verbal request comes after the first one, and there's a 15-day waiting period between the two. And we are trying to, in the new law, we are trying to have that omitted in case of patients who are in severe distress. When we do these presentations, people really want to understand more about the medication itself, which is a reasonable request. So physicians can call our hotline, and we'll have that number later, to discuss the medication options with a Compassionate Choices medical advisor. And it's usually Dr. Grube, Grube is our national medical advisor, and he's a wonderful, wonderful man. And they can call to obtain the names of pharmacists who will fill that prescription. The prescription is made by what we call a compounding pharmacy, and they prepare the medications and mail them to the patient's home. And the shipping times range from overnight to 10 days. I don't recall, Steph, in your case, how long it took from the time
2 days.
2 days.
It was done in Northern California, and they FedExed it, and it was there.
Right.
And as soon as we got it, we used it.
Right. Obviously, the medication needs to be stored in a safe place as directed. And as Steph mentioned before, that many patients will have it on hand, and some may not use it, but they have it. It arrived at their home weeks, maybe a month or two before they intended to use it. So it varies with the patient.
So with our hospice, we completed the registration and we immediately signed a request for medical aid in dying. And the prescribing physician was at the hospice, and he came out to our house so that he could validate our first official verbal request. And then they arranged a meeting. This is the FaceTime thing that I was talking about, so that our eligibility could be confirmed by a second doctor. And I talk about it as our eligibility. I know it was really Richard's eligibility, but we went through this together, and it just seemed like a joint thing. And then after waiting the required 15 days, we did the second verbal request to the prescribing physician, and he came out to the house to look and check Richard out and see how he was doing. And that worked well. Then the hospice submitted the medication request to the pharmacy. They shipped it by FedEx, and the question that everyone asked was, well, how much did it cost? And because Medicare does not pay for this medication, so it's important that everybody is aware of that. And it cost us $700, and it was the best $700 I ever spent.
So this slide also discusses the cost of medication. Medicare does not cover the cost because it's a federal program and this is a state law. And Medi-Cal does cover the cost in the state of California because Medi-Cal is a state-run program. And we ask you to check the prescription plan for coverage, but it's unlikely that it would be covered. But I guess there are certain, I think maybe in Kaiser it would be. The prescription cost ranges, it's approximately $500. For Steph's situation, it was $700. I guess it varies by the compounding pharmacy that's used. So these are, on this slide, we're going to cover the details of the medication ingestion. And a commonly used end-of-life prescription includes the following 3 stages. There's a phase called pre-medications, and this is to prevent nausea and vomiting. And it's taken 1 hour before the medical aid in dying medication itself. And I know we're being graphic, but people have always asked us for the details, so here they are. The second is digitalis, and that slows the heart. And it's taken 30 to 60 minutes after the nausea medications are taken. And then the final is the actual aid in dying medication. And this is the end of life medication, and it's taken 30 minutes after the digitalis. And the final medication, Steph, comes as a powder, right? And it's mixed with the liquid prior to the ingestion. And taking sorbet or something cold between the swallows of the medication can help to counteract the bitter taste, because the medication needs to be ingested, the end of life medication needs to be ingested, I think, in a time limit of 1 minute or 2 minutes. And what it's bitter, so some patients might hold back on ingesting and swallowing all the liquid. So the ice cream or sorbet helps with the bitterness to help them take the next sip. And the time to death from ingestion ranges from 5 minutes to several hours. And they have found that prior food ingestion can extend the duration of the process if someone has a big breakfast, for example. And the support of hospices will allow the hospice nurse, as we said, to be present at the time of ingestion, which is a great source of comfort to families.
So one thing I'd like to say is about the 1 to 2 minutes that Susan talked about. One of the reasons that they talk about that is that they're concerned that the previous medications that you take are going to make you sleep, and you need to take this stuff before you fall asleep. And so that's what the push is, to do that as quickly as possible. So on our chosen day, or actually ahead of our chosen day, Susan and another friend and the hospice nurse came to the house, and the pharmacy had provided extremely clear directions regarding the timing and the ingestion of the 3 medications prescribed. And I will tell you that the hospice nurse who was on her way to the house was really concerned that I didn't understand the directions, and that so she kept going over what I needed to do when, and I tried to reassure her that I knew that, but to no avail. So when it was time for the final medication, the nurse fed Richard some frozen ice cream at intervals between sips to buffer the drink's bitterness, while I had the cup as he sipped through a straw. Because in terms of the self-ingestion, the hospice nurse doesn't want to be the one helping the patient take the medication, and they want them either to do it themselves. Well, they require it, they do it themselves, but certainly a spouse can hold the cup and help along with the process. And the nurse monitored his heart activity until he passed. And the whole process from the initial medication to the end took about 3 hours. And I just have to say that the law that passed in 2015 would not have happened without Compassionate Choices and all the wonderful Compassionate Choices volunteers. And it allowed Richard to choose the method, time, and place of his death, for which I will be forever grateful.
I just want to say how honored I was to be there, and it was a special time, and I was thrilled that Richard was able to be in control of the situation with Steph's help. We have support information for physicians and patients. There's a wonderful doc-to-doc consultation line, and you can see that on the website. But often what happens is a doctor might want to help but not be sure, and then the patient can give their doctor, if they're going through the doctor of their private practice, this phone number to call. There's also support for patients and their families. At the same phone line, you choose the correct number and you leave a message, and then the support staff will return the call. And that's how the protocol works. You leave a message and they get back to you.
So one of the things that we always talk about is the California Compassionate Choices website. Um, it's a website that I complain about with great regularity, as Susan can tell you. But given that, there are some amazing resources on this website. So this is what, when we captured this was what the screen looked like. I'm sure that it's different today because it probably has a lot about Senate Bill 380 on it. But they've got good resources in English and in Spanish. And they have toolkits, including a COVID-19 toolkit. And then you can go over here and click. These are all links where you can find out more about the End of Life Option Act and events that they're holding around California regarding medical aid in dying. And so we do want people to do that, and you can see there was a take action against the partnership of UC San Francisco with Dignity Health, another one of the many Catholic sites. So we were asking people to do that. And perhaps the most valuable tool on the website is the Find Care tool, because you want to be able to find supportive hospices. You want to be able to find a supportive hospital, and you don't want to have to go from hospital to hospital or hospice to hospice to try and find out what you want. So this can be very valuable. So what you do is you put in your zip code, and then you can put in a search radius in miles, and you can search either for hospitals or for hospices. And so we put in the 92831 zip code, and we were looking for a hospice, and lo and behold, here's Valley Oaks Hospice. And they say that they will support and be present when the self-ingestion is being done. They will do the prescription for you, and they will be the medical consultants for you. So, and each hospital and hospice that you find when you're using this Find Care tool has something about each of these three statements, and it will say yes or no. So it's important that you spend some time looking for the one that is going to be right for you.
I wanted to add on that previous note that the other hospice is called Seasons Hospice. So there's Seasons Hospice and Valley Oaks. Valley Oaks is in Orange County and Los Angeles. I'm not sure about Seasons, but both are supportive of medical aid and dying. On the website for Compassionate Choices, they have resources available in English and Spanish. And Steph, do we want to say any more about that?
I don't think so.
No, you can just see that it's in both languages there. Okay, and then the next slide is, Steph already mentioned it, but there's additional tools. If you look at the bottom, it's the COVID-19 toolkit, which Steph and I have both used. We downloaded the documents, and I have them all ready if I should have to go to the hospital for COVID. But now that I've had the 2 vaccinations, maybe not. But anyway, you spell out exactly what you want to happen and not happen. And you have to look at the questions. They're very thoughtful. And you have that all filled out. And it does help the doctors because they're just trying to do the right thing. And if they don't have guidance, they're not sure how to proceed. And one of the other things up above there, they have the advanced directives. And you can get it by your own state. And it's the DNR and the Pulse. And we don't need to go into all of those now, but they've also taken a lot of leadership with dementia. And even though you have to be of sound mind to use the current bill and the bill that's proposed, they do have the option for ahead of time letting family and medical people know your wishes if dementia were to be a challenge that you would face. And they're very specific about, if I'm not able to do this, I do not want life-sustaining treatment. And it's very well laid out. So those are very helpful tools that they provide.
So this slide is just a simple slide that talks about the Advanced Care Directive and the Pulse form. And so the idea is that all adults, and almost adults, I think, should have an advanced directive, because you never know when you're going to need one. And it's important that people update it periodically. I know I updated mine after Richard died, but I probably should have updated it more frequently than that. And when you're diagnosed with an advanced illness, or you're frail, then you should complete a POLST form. That is done with your physician. and you should update the pulse form with your physician as your health status changes. Um, I think I'm going to lose power for some reason.
Uh-oh.
Bear with me, everyone. Um, and so the pulse form should be clearly posted in your house when, medical personnel come. Usually they say, have the pulse form done in bright pink and put it on the refrigerator so that the medical personnel will see it and know what they can do and what they can't do, and how they should operate. So some final words of advice. Uh, Obviously, you need to use caution when choosing the right hospital or the right hospice for you. And if you have a terminal diagnosis, you definitely should have identified a hospice for yourself. And even if you don't have a terminal diagnosis and you are giving thoughts to this, it is a good idea to know what the supportive hospices are around you. You need to speak to your family in order to clearly communicate what your end of life needs and wishes are. They should be documented in writing, and it's a great idea to record a video on your phone and send that video to your family members so that there are no questions at the end. If you have a terminal illness, a call to 911 will most likely result in additional procedures to prolong life, and that's where it's important that you have your pulse. If you elect to go to the hospital or even just visit your personal physician and you are in hospice, one of two things will happen. Either the hospice will kick you out of hospice or your insurance will not pay for the visit. And this was something that happened to Richard. He had a visit with his um, physician after he was in hospice, and sure enough, we got a bill because the insurance would not cover it. But we were very, very happy that he wasn't kicked out of the hospice. So
What happens is that when you join a hospice, you sign over to the hospice all the insurance benefits. It gets transferred,
right,
so you no longer have the other option. Yeah.
yeah,
Okay, so as with all organizations, we're on social media, Twitter, Facebook, YouTube, Instagram. And it's time, Steph, for questions if anybody has them.